Hello everyone, welcome to Peripheral Nerve Ultrasound Case Diaries. In today's video, we are going to discuss a rather rare cause of ulnar neuropathy in a young girl and how nerve ultrasound helped in arriving at the accurate diagnosis. This was a 19-year-old female student from an allied class. She presented with complaints of tingling, numbness and paresthesias involving left little and ring fingers since few days. So, very classical history of ulnar neuropathy. There was no history of trauma, no history of snapping ulnar nerve, no skin lesions or no history of leprosy contact. Clinical examination was highly suggestive of ulnar nerve involvement. There was positive tenal sign over the cubital tunnel, positive Froment sign, and ulnar nerve was also just palpable behind the medial epicondyle. So with this clinical examination, she was referred for ultrasound of elbow to rule out the cubital tunnel syndrome. Let's assess this patient's ulnar nerve objectively on the basis of certain parameters. We will assess ulnar nerve size, echogenicity, internal architecture, intraneural vascularity, and epineural thickening. So let's look at these one by one. Coming to ulnar nerve size and echogenicity. This is the ulnar nerve image taken at the level of mid-arm. We can see the nerve looks pretty normal. There is maintained polyfascicular pattern, hypoechoic fascicles, hyperechoic perineurium, maintain normal polyfascicular pattern. However, as we move distally, this is the cross-section axial image of the ulnar nerve in the distal arm. We can see the nerve is significantly thickened, there is loss of normal polyfascicular pattern, and there is reduced echogenicity. Again, in the cubital tunnel, nerve is significantly enlarged and there is loss of normal polyfascicular pattern. Just distal to the cubital tunnel, again the nerve is enlarged. However, as we move into the proximal forearm, nerve becomes normal in caliber. In the mid forearm, it is normal in caliber with maintained polyfascicular pattern. So, there is predominant enlargement of the nerve in the distal arm, cubital tunnel, and in the very proximal forearm. This is the tabular data showing a left ulnar nerve CSA at various levels. In the distal arm, nerve is significantly thickened, reaching up to 0.67 cm square CSA. Also in cubital tunnel, it is 0.30, just distal to the cubital tunnel, it is 0.22, and later on, more distally in proximal mid and forearm as well as in Guyon's canal, the nerve is pretty normal in caliber. So is it a cubital tunnel syndrome? For the diagnosis of cubital tunnel syndrome, the ultrasound criteria are there is enlarged left ulnar nerve CSA more than 0.11 cm square and distal arm to cubital tunnel ratio, if it is more than or equal to 1.5, it points towards cubital tunnel syndrome. So both these criteria are satisfied in our case. So is it a case of cubital tunnel syndrome? Let's not jump on the diagnosis and we will assess other parameters. This is the panoramic image which again nicely depicts the long segment diffuse hypoechoic thickening of the left ulnar nerve. If we do side-to-side comparison, this is the right ulnar nerve CSA in the distal arm which is 0.11 cm square and left ulnar nerve significantly thickened hypoechoic 0.67 cm square CSA. As I said, we assess the nerve on different parameters. So let's look at the internal architecture. If we assess the internal architecture, what we can see is there are multiple anechoic areas, cystic areas within the nerve. This is the image at the level of medial epicondyle and we can see there is large anechoic area within the nerve and there is complete loss of normal polyfascicular pattern. If we put on color or power Doppler, we can see there is significantly increased intraneural vascularity. These are the longitudinal images which also show there is significant increased intraneural vascularity. If we look at the epineurium of this nerve, it is significantly thickened. There is increased echogenicity as well. So if we combine the findings, we have this diffuse long segment thickening of left ulnar nerve, which is extending from left distal arm up to few centimeters just distal to the cubital tunnel. Along with, there is reduced echogenicity of the nerve, there is loss of normal polyfascicular pattern, multiple anechoic cystic necrotic areas within the nerve, increased intraneural vascularity, and thickened epineurium. So, if we consider all these features together, what comes to our mind is the diagnosis of pure neuritic type of Hansen's disease. This patient's quantitative PCR was done, which was positive for Mycobacterium leprae, and she was started on multi-drug treatment, and now she is completely asymptomatic, completely disease-free. So when to suspect pure neuritic type of Hansen's disease? In endemic countries such as India, whenever there is presence of mononeuritis along with tender enlarged nerves, one should always raise a suspicion of pure neuritic Hansen's. Clinical diagnosis is based on thickened peripheral nerve trunk tenderness and sensory impairment. However, the diagnosis is often challenging to the clinician as there are no skin lesions, and split skin smears, which are very characteristic of leprosy, are negative for acid-fast bacilli. Histopathology, that is nerve biopsy, is definitely confirmatory. However, it is very difficult if you have pure motor nerve involvement and it is the sole nerve which is involved. EMG NCV studies results are very non-specific and FNAC is not very useful. In such scenario, high resolution ultrasound with its ability to exquisitely demonstrate the intraneural architectural changes is an incredible tool for accurate objective assessment of the nerve involvement. It can demonstrate presence of intraneural necrotic areas, intraneural abscesses, as well as increased intraneural vascularity, all of which are considered the hallmark for Hansen's neuropathy. I hope you find this video informative. Thanks for watching.